Good morning, all friends. So this is our second live case this morning. So we just finished one very complex PCI for distal left main trifurcan lesion. Now it's time for TAVI case. Dr. Zhang now is a leader of structural heart disease in my department. So I think this will be a very important case sure to introduce how to do TAVI, particularly in the scenario in China. So Dr. Zhang, go ahead.
Okay, thank you very much, Professor Chen. So this patient was admitted with recurrent chest pain for 6 months. Actually, it's quite a younger patient, only 65-year-old. So this patient has no comorbidity. NT-proBNP was normal, and the EGFR is also normal. ECG show normal. So after we calculate the active score, only 2.75%. It's a low-risk patient. So let me show you the baseline TT echo. So from the echo, you can see it's a typical bicuspid valve, and also with a severe aortic stenosis. The velocity maximum is 4.2, and the mean gradient is 41 millimeter mercury. Accordingly, the area of aortic valve is 0.8 centimeters square. In terms of the LVEF is normal, 65%. Left ventricular diameter, diastolic diameter is smaller, only 45 millimeter. In terms of pulmonary artery systolic pressure, a ritual high, 42 millimeter mercury. So you can see it's a typical BAV case. Then let me show you the CT analysis. It's quite important for these patients' valve sizing. In terms of very important anatomy, aneurysm diameter is 21. In terms of LVOT diameter, 5 millimeter level is only 20.7 millimeter. And you can see it's a typical BAV case with calcification, not so severe. So in terms of the peripheral artery, you can see the elite femoral artery diameter is 6.3 millimeter. It's not enough for us to use femoral artery. And another important anatomic characteristic is aortic arc angle. You can see only 62 degree. It's quite small. So finally, our procedure strategy, according to the CT analysis. So we decided to treat this patient with a TAVI procedure. We will use a general anesthesia with a T guidance, considering it's a typical BAV case. So with the T guidance, we are precisely implantation the valve depths. And also we were from the right femoral approach. We will use 20 balloon do the predilation, then followed by 23 millimeter. Tonus Elite self-expanded valve. It's a domestic valve. Oversize ratio is 1.16 with a snare facilitating aortic arc crossing.
Your next step.
Yeah, next step, let me show you. I will start my procedure, Professor. So I will insert the long crest wire. It's a support wire, very, very strong support of the valve device crossing into the LV valve. So you can see this is not pre-shipped wire. So I use this cassette to shape the wire. There is the curve to facilitate the wire stage just at the apex of the ventricular and supply strong support. Then I will still use this previous 20 millimeter broom, try to cross the stenotic valve with a snare to facilitate the cross. Please change the angle. I go to the HG. Hold the wire.
By using snare,
Yeah, I will use.
do you still want to downsize the balloon for predilation?
Yeah, if this balloon cannot close, I will use a smaller balloon. Just to mention the downside, maybe T or 60, 80 or 16. Yeah.
Because a predilation balloon is quite long.
Yeah.
So it's not easy to cross very severely the stenotic valve.
Yeah, I think. Okay, we try.
For some cats, it will be not much more easily to catch the wire.
Still, you see, I need a small size. Yeah, balloon. Drop. Please give me 16. Do you have a small size balloon?
16 in diameter.
Of the wire? Yeah. You see, now the tip float. 有间隙，smaller. Yeah, good. Very good. Hold the wire. Okay. So at these times, I think more AIO. More AIO. Okay. So my second operator will hold the snare and change the angle. Hold the snare, change the angle, or lose tension. Advance the wire. Yeah, you see quite a lot of resist. You see, we successfully close. But it's not so easy. At this time, I will lose.
It's successful.
Okay, okay. I successfully with the snare facilitating the balloon cross. Good.
The table.
Okay. Rapid pacing, 118.
Pacing on. Pacing on.
180.
Okay.
180。
Okay.
Good. The balloon was fully expanded. So usually, how long duration of inflation?
I think at most 5 millimeters.
It pays off, right?
It's off, yeah.
Now snare is in.
Yeah. Auto AP, yeah. Snare is in. Okay. The snare. 拉一下。等一会儿。
So you always need to simultaneously push snare and the balloon.
Yes.
I think you got it.
Yeah. Okay. We successfully snare. Okay, so at this time, because you see the angle is quite large, so you should snare, hold the snare cassette, change the angle, please hold the wire. You see, quite a large angle. Okay, we successful. Not so easy.
Congratulations.
Okay. Okay, rapid pacing.
Pacing on. So now the pacing rate is 180. Okay, this is 20 balloon.
Very good. Now we will quickly insert to the valve. Hold the wire, please. At this time, I think considering it's
The wire is in apex, yeah.
Yeah, I think quite a lot of resistance. Cannot. Yeah, we should. Yeah,
remove the pigtail.
Remove the pigtail. Yeah. Yeah, I think so. Yeah. We should remove the pigtail first. Please hold the wire.
Why?
Because there is a lot large enough sheets can simultaneously accumulate the. First, we should insert the insert
Diameter is small.
smaller, yeah, because it's the females. Okay, good. Very good. Then hold the wire, please. Then I advance.
Still not easy.
Yeah, I think that is easy. 别拉太紧，稍微是。Hold the wire. Still, I think a lot of resistance. Oh, good. I think.
Angiography, the angle has been modified much more.
Yeah.
But the angle between descending and ascending aorta is very sharp.
看下面。能不能出去 ？Okay, good. Loose，松掉，松掉，对。You see, I simultaneously insert. Not so easy. Okay, hold the wire. 松掉，松掉。松掉，看下面。
Very narrow space.
Yeah, very narrow space. 小心。再往上走。对，好 ，very good, very good. 再往后侧一点点。
For some cases, for example, for let's say 65 years old lady, so do you think puncture the left side is another option?
Yeah. Yeah, here. Then we hold it. No, still more. Okay, good. See the wire? Because we're damaged. No. Cause dissection. You see? No, no, no. Just 1 minute.
Pushing more now.
Yeah. So it's a tough case. I will advance the snare to the tip. At the tip, maybe there is a. Okay. 再往前 loose. Okay, good.
Oh, I'm sorry. So can we still have 2 or 3 more minutes? Because this is a very, very important step to put the valve in.
See?
Okay,
Yeah.
thank
Good.
you. Thank you.
Thank you.
Yeah, now you are successfully crossed the valve using the valve.
Yeah. Okay. The test, please.
Yes, then define the appropriate position.
No. 打成一条线，让孔博来做。
So I think this step is very important. Junjie, can you explain how to define the position?
Yeah, at this time, I think in terms of the bicuspid, actually, sometimes very difficult to do the decision. With TE, we can see clearly. This view is very important. Separate the bicuspid. Let me take a picture at this time. You see? Okay. Can we start to release the valve?
So usually how long protrusion of the valve into the LV?
I think 3 millimeter or 4 millimeter. Pacing, ready? 114.
Pacing on.
Okay.
Okay, so
okay, release.
So
Gently.
very gently, very gradually to
And test,
release
please.
the valve.
Good, very good.
So now I feel the protrusion is greater than 5 millimeters.
Yeah, less than, yeah.
Yeah,
好吧，
把单的 mat
后头的瓦也顶一下导丝。
by the down the mat after almost
Okay.
2/3
This is
valve
good. Yeah.
Good.
Good. Yes.
release.
Yeah.
You still can retrieve.
放进去一点，怎么样 ？OK。Release
到了临界了吗？
放赢。I think the position is good. What do you think?
I feel good too.
I think
Good.
a little sleepy. Yeah.
Good position.
Yeah. Position.
Yeah, do you want to take a picture?
Yeah. Stop facing. The BP. I pull out the wire.
Because we only have 2 more minutes,
Okay.
so we need to take a photo.
Okay, hold the wire. Be careful.
So usually, Dr. Zhang, do you plan to do post dilation?
Yeah, just a minute. I think for this case, I think there is the risk I will do the put dilation. So
导丝握住。
Where is now?
yes, made here. Okay. Good. Zhang Juan, can you show the echo result?
Yeah, angiographically, there is a severe regurgitation.
I think it's
Regurgitation is central.
central.
Yeah.
It's caused by the wire. There is I think
Okay.
there is no PVR for this
Yeah.
case.
Okay.
Yes. From the echo, the position is good and the valve is stable and no PVR.
Yeah.
Maybe trivial. And there is severe central regurgitation. Yeah.
Yeah, this is because of the
Wire.
stiff wire.
Wire,
Yeah.
I think so, yeah.
So I think this is very, very successful case of TAVI for a young lady with bicuspid aortic stenosis.
Thank you, Prof. So for this particular bicuspid aortic stenosis, for this low risk patient, I think the baseline echo and the CT analysis is very important. According to the CT analysis, we should select the proper sizing valve. And during procedure, you can see for this challenger case, actually the angle of the aortic root and the LVOT is quite large, which will give us the difficulty to cross valve into the LV. So with a snare support, change the angle, we successfully advance the balloon and the valve into the right position. So after release the valve, you can see the result is good. So for this case, it's a superannular valve. So compared with the intraannular valve, I think can supply and give a larger EROA. So for this young patient, I think the EROA is a very important characteristic for this long-term result. Thank you for your attention.